Good morning. We'll give it a second to catch up here. It says it's starting. Well, there we are. Good morning. Good morning. It is Saturday. Can you believe it's Saturday already? I'm so excited to be here. It is May the 8th. It's the day before Mother's Day, and I am very happy to have a day to be able to get caught up. I'm sure you guys feel the same way. Um, so today is Saturday, May the 8th. Tomorrow is Mother's Day, and I'm just going to give it a second here for a couple of people to hop on live. It is, I gotta I gotta pull this up because every now and then I seem to have a little bit of trouble with um, my live stream. Um, I don't know what's going on with it. Sometimes I cannot see comments. So if you guys are out there, please click on live. If you are joining in the replay, please say replay. For some reason this morning I'm kind of nervous, and I don't know why I need to be nervous. I've done this, this is the 24th time now, so I shouldn't be that nervous anymore. So here's my quick little introduction yet again. Welcome to the Baffled Brain, Demystifying Dementia, the weekly hour-long Facebook Live that will teach you everything you want to know about how to manage dementia. Today is May the 8th, and this is episode 24. Can you believe that? It's almost been a half a year. And I'm your host, Lizette Kluta from Think Different Dementia, where we believe caregivers deserve reliable and accessible answers to questions, because providing caregivers actionable strategies and reliable information gives them and the person with dementia their best quality of life, improves their relationships, and delays their decline. So today I have a couple of questions over here. If you have ever joined me before, I really do rely on you guys to actually put some questions in the comments. I do answer them. I try to if I'm not having trouble with my live stream. And then I will come back afterwards if somebody has a question, and I will actually answer them. If you've been around me for a bit, you know that I will message people if people have questions for me. I have a few people that consistently message me questions. So if you have any questions out there, please drop them in the comments. If you don't want to do that, if it's a private question, please message me at Lizette Kluta OT, and we will be happy to answer your questions. So good morning, good morning, good morning. Alrighty, so here is my first question of the day. Hi Lizette, here are a couple of issues we've been dealing with. Our loved one eats or tries to eat things that are inedible. Have you guys had that happen before? For example, greeting cards, foam rubber seat cushions, puzzle pieces, etc. And our loved one has become more withdrawn lately, doesn't engage in can't speak English today, doesn't engage in conversation, just sits and fidgets with things. And this question was from Tracy, and I answered this in my private Facebook group called Think Different Dementia earlier. So a couple of things she said. Her loved one eats or tries to eat things that are inedible. Greeting cards, foam rubber seat cushions, and that one kind of surprised me. Puzzle pieces, and that they've become more withdrawn lately and doesn't engage in conversation, just sits and fiddles with things. So so that is actually a very common thing, right? It's called pica. It's actually pica is a psychiatric disorder, and I'm not saying people with dementia who are eating things that are inedible have pica, but pica is actually a thing that people will do when they really when they have a significant problem. However, in the case of people with dementia, I think what happens more there is they lose the awareness of what is truly edible versus inedible. So let's talk a little bit about executive functioning, because this kind of ties back to executive functioning. Executive functioning are the things that we we have that are our higher level thinking skills. So as a person is born and they grow up and everybody develops, right? They go through certain normal phases of development. And as they're going through their normal phases of development, people will start to, when children are little, right? What do we tell them all the time? Don't eat that. Don't put that in your mouth, those kinds of things, right? So think about a little kid that's playing outside in the dirt. They have their hands in their mouth. They're always eating these things that are inedible. They'll try to eat bugs. They'll try to eat all sorts of stuff because they really don't know yet what is truly food or not food, or they just, we have a hand to mouth reflex. So as people continue to develop through their developmental milestones, we become aware of what we can and cannot eat, what we should and shouldn't eat. And then we become an adult and we have our higher level thinking skills, right? So in our higher level thinking skills, which are called executive functions, in our executive functions, we have things like time management, we have anticipating consequences of things, we can reconstitute information. Think about the old game telephone, right, where somebody is talking to you. You give a message to one person and the message is transferred from person to person, right? Well, reconstituting information is kind of like that old game telephone. So we take information and we have to go to the grocery store and we have a list in our head of, for example, my daughter's graduating college next week and we're wanting to make some malktat, which is a South African dessert, and I have to go to the grocery store and I have to buy milk and I have to buy this and I have to buy that. And all of these things are called, when we're using that and we go to the store, I have to be able to reconstitute that information in the store in order to be able to remember what it is that I want. So executive functions are the higher levels thinking skills. And so as we're working with, back to the question at the beginning, which was our loved one eats or tries to eat things that are inedible, as people start to lose their executive functions, they start to have difficulty with knowing what is edible and inedible. And so this person had said that they eat greeting cards, foam rubber seeds, that one was interesting, and then puzzle pieces. And they're probably doing that because they're starting to lose the ability to recognize what is or what isn't food, and they're just getting to a hand-to-mouth phase. And then the second part of it, the question that they said, was that their loved one has become more withdrawn lately. They don't engage in conversation, just sits and fidgets. And so what I would like to say to Tracy is that that's also probably, as they're losing their executive functioning ability, people lose the ability to initiate doing things. It's not that they don't have the desire to do activities anymore. They just lose the ability to initiate that on their own. And so what they need from us as their care provider, what they need from people who are walking with them through this journey of their dementia, is when a person starts to become a little bit more withdrawn, we need to be actively engaging them in their environment, right? So how do we do that? What kind of things can we do? We want to know what they were interested in before. If you know what kind of hobbies or interests people had before, you can engage them in those activities. You don't have to make those activities so hard, and it's not that we want those activities to be perfect, right? Those activities don't need to be perfect. We're not looking for the product, the end product. We're looking for the engagement in the activities or in the tasks. So we can bring people together and have them do things together with us without having them feel like they have to perform. We just want to actively engage them in their environment. And so that's what I would, people even at the end stages of dementia can do simple things. We just have to make it easier for them. We don't want to expect. So there's another thing, right? So people with, what's the difference between Melissa, who's an occupational therapist, and me? I'm also an occupational therapist, and family caregivers, sometimes one of the biggest differences, Melissa and I have been trained to be able to identify this is where the person with dementia is actually functioning, right? And then other people, so family caregivers, family providers sometimes overestimate the person with dementia's abilities, and that causes frustration. Or they underestimate the person with dementia's abilities, and that causes them frustration because they're able to actually do more than what we're allowing them to do. So, some simple things that you can do with people: give them something to sort, have them help in the kitchen. You know, if they look like they're still able, just give them one task to do, not 14 different things. So when somebody isn't engaging in their activity, in their normal activities, and become withdrawn, we want to engage them. We want to initiate for them. Hey, Melissa, thanks for joining. Ken says, is not eating appropriate for the brain essential, and does that mean not eating healthy alone? A strong association exists between lifestyle factors and Alzheimer's. Unhealthy dietary factors have been linked to neurodegeneration. Specific prudent dietary patterns may help in preventing. Yes, so that's a different conversation. And yes, there's a lot that we can do to prevent dementia. And thank you for bringing that up, Ken. I'm a firm believer that there are things that we can do to prevent dementia. I think that there is, and this is not a very popular topic out in these larger groups where a lot of people feel or believe that it is done and there's nothing that we can do. That is not what I believe. I believe that the sooner we start doing stuff, the better. Diet, exercise, sleep, and stress can play a significant role in our brain health. And there's more and more indication coming out in the research, as Ken has indicated here, that there are things that we can do to promote our own brain health. And diet is one of those. And as you start to look at, as he's put out there, the microbiome, as you start to look at those kinds of things, Dr. Bredesen frequently talks about up to I don't remember exactly how many, 26 if not more individual factors that can contribute to our brain health, and that our genetics do play a role, but our genetics do not mean that just because we have a genetic predisposition for something that we are going to develop that over time. And so it is very interesting to see, to me, how much a person's cognition can fluctuate just based off of some changes in diet. And so I actually started following, doing the Bredesen protocol, loosely doing the Bredesen protocol for the past year, and has truly noticed that that has made a significant difference in my own thinking processes. So we'll talk about that for a second, right? So there are different levels of thinking, right? We have, the first thing is subjective cognitive impairment. So what is subjective cognitive impairment? Well, subjective cognitive impairment is, I know that there's something wrong with my thinking, but nobody else will know. It means that I didn't sleep well, I didn't eat well, I haven't eaten well for the past month. My husband's been up in Greenville working on our duplex, trying to get that fixed. I always used to think I cook for my kids, but I don't. I cook for my husband. When my kids and I are home alone, my daughter and I have been home alone for a week, I'm like, fend for yourself. When my husband's home, I cook for us and we eat better. So I've noticed, so that's subjective cognitive impairment, right? So I noticed that I'm not thinking as well, or I'm not thinking as clearly, but nobody else would, and a test won't show that either. So the next phase underneath that is called mild cognitive impairment. Well, mild cognitive impairment just literally means And it doesn't mean that it is not impairing, which makes people confused because they say it's mild. Well, no, it may be mild, but it can have a significant depth. It can have significant impact on your daily functioning, right? Just because a deficit is mild doesn't mean that it doesn't have an impact. So mild cognitive impairment is the next phase. And what mild cognitive impairment is that pre-dementia phase. And research has shown that over the next 5 years, people with mild cognitive impairment will actually convert to mild dementia if we don't start to do things differently, right? And just because we are having trouble with our thinking processes, it's never too late to start doing something. There is always things that we can do to improve our thinking. Our lifestyle plays a big role, right? Diet, exercise, sleep, and stress. And we say that all the time. And there are better diets than there are other diets. They've also started to show that blood sugar plays a significant role in our ability to maintain our own cognitive health. There are better cognitive exercises that we can do. There's actual strategies that can help. Sleep hygiene can play a big role. And when you have a person with dementia, even mild changes in this can make a major big difference in their ability to function. So that's mild cognitive impairment. Then the next phase under that is mild dementia, right? And that is where we really start to see some of these changes and then mild to moderate and then severe dementia. Does anybody out here on the live have any questions for me? This is usually what I rely on you guys to give me questions so that I can answer those. So I kind of got off on a tangent because Ken had made some comments on the microbiome and brain health and cognition and so on. So I'm not going to be reading all of those comments again. But anyway, there are 3 primary ways you can get a hold of me. One is you can message me. My name is Lizette Kluta OT. You can message me. Number 2, you can join my Facebook group called Think Different Dementia. And number 3, you can what is the third way? You can email me. Oh, you can subscribe to my YouTube channel called Think Different Dementia. Susan, glad you're out there. All right, let's read Susan's question. My maternal grandmother had Alzheimer's. That's what they diagnosed. And now my mother is suffering from this. We noticed her changing at age 74, 6 years ago. Prior to that, she walked daily, stayed active in 3 different organizations, traveled, and purposely did these things to avoid dementia Alzheimer's. At age 51, I struggle to think it's not genetic. So yes, Susan, there is a strong genetic component to some dementia. Not all dementia is genetic. But just like with breast cancer or colon cancer or any of these kinds of other things, not all, not th- just because something has a genetic predisposition doesn't mean that you're going to get it. There are things that you can do. So staying active is great, traveling is great, all of those things to avoid dementia are great. But when you start to read some of the newer research coming out, they are starting to find that all right, and I have to take a second to get my brain to catch up to your question, so forgive me for a bit. So think about it this way, right? There are certain things, there are certain disease processes, there are certain things that are what we call a monotherapy. There's one way to treat it. So, for example, pneumonia, right? Pneumonia is caused by a organism and can be treated, if it's a bacterial pneumonia, by a monotherapy, which is a one type of medication, right? It can be an antibiotic, it can be whatever medication, monotherapy. Think doctor prescribing a medicine for something. That's a disease that is caused by one thing. What they're finding with Alzheimer's is there is a genetic predisposition for some people, but there are up to, and I forgot today, how many different factors that can contribute to Alzheimer's. And how they've started to show that is that, the medications that are out there for Alzheimer's to delay, because it doesn't stop the process, those are monotherapies. That's one drug that's plugging up one hole. And they're up to 26 or 34 or whatever different little factors that can cause dementia or Alzheimer's. And so if your mom had been doing the exercise and the sleep, so exercise is one, sleep is one, stress is one, all of these different things are parts of these holes that are in the roof, right, that can contribute to dementia. So yes, if you have a genetic predisposition to dementia, you want to make sure that you are doing all of these other things and plugging up as many of these holes as you can so that you decrease your risk of doing that. Blood sugar is one, sleep is one, maximizing your nutritional input, minimizing inflammation, minimizing infection, all of those things. And that is not what I do. There are actually people who do these kinds of things. And there's a Dr. Bredesen protocol person in this group. Her name is Robbie Parker. And I'm just going to put her name in the comments. She's a Bredesen protocol. She's a Bredesen protocol coach. So what Robbie does is that is her business. She works with people who are truly and that's a whole totally different business. I kind of thought about going into that, but that isn't my strength. My strength is being an occupational therapist. So Susan, I hope that helps you a little bit. I don't, I'm 50. My mom has vascular dementia. My dad definitely is starting with some changes. Alcohol is a major big thing in their lives. And so when you have all of these additional factors, what you want to do, Susan, is you really want to try to maximize all of these different factors. And it's not just staying active and traveling and keeping your brain active. There are other things that you can do. So I hope that was helpful to you, Susan. Now, if you do want, I do cognitive testing with people. If you do want a cognitive test, I'm able to do that. So you can reach out to me and we can set up a consultation if you wanted to do that, to actually see how your brain is processing information. And if you truly are having difficulty with your own thinking processes, I've done it with myself. I plan on doing one of these tests every year and monitoring my own cognition, since there is a familial none of us have been genetically tested, but I definitely think that there may be a component of it. My grandmother in her later life definitely started to have some cognitive impairment, and I truly believe that it was, I truly believe it was diet related for my grandmother. So I'm walking this walk with you guys. I'm not just sitting here as a therapist. So back to Susan. Thanks for putting her name out here. Do I feel one of these factors can be anesthesia for surgery? Yes. Your dad seems to deny the Alzheimer's diagnosis, as he says you don't know until an autopsy. Right. So your dad is actually correct as of right now. And things change things change by the minute. So as far as I am aware right now, the only definitive way to truly diagnose Alzheimer's is on autopsy, because what they do is then obviously after you've passed away, they open up your brain and they take a look and they find plaques and tangles. Well, let's talk about plaques and tangles for a little bit. There is a study out there, Susan, if you're interested. It's called the Nun Study, literally the Nun Study. And you can go Google the Nun Study. Well, the Nun Study, and it's been a minute since I actually researched this. I did a whole course for occupational therapists that's about 4 hours long on preventing dementia. And so if you're interested, email me at Think Different Dementia and I will send you the course, just because I love to share Um, it's not that complicated that you wouldn't be able to think different. I can't type and talk, right? Think different dementia at gmail.com. And anybody, think different dementia at gmail.com. Anybody who's watching this on the live or the replay, if you're interested and you email me, I will email you that 4-hour course that I did on how to prevent dementia. It's got a little bit more detail than I can go into. It's got a slide presentation and everything. So the nun study, back to the nun study, what the nun study was they studied nuns, literally nuns, in a nunnery for decades, and the nuns were very highly functional. But when they went and they did, they had no overt signs of dementia, but when they autopsied them later on, they found the plaques and tangles. So just having plaques and tangles doesn't necessarily mean that you have functional decline. When you go into the whole the Bredesen protocol is fascinating. It truly is. When you go into and you know, I'm on the spot here because it's Saturday morning and I don't have my presentation with me. But what you do find is that plaques and tangles might be our body's normal response to things, and we should have them. But there is an abnormal response and then a normal response. So I'm not going to keep talking about that because I'm going to dig a hole for myself. If you are interested, email me and I will send you that presentation. It'll be like in a YouTube link, which I'm not going to put out there because it's, you know, my information, but I'd be happy to share it with you, and you're free to watch it or not watch it if you're interested. So anybody out there have a particular question? We kind of got on a little tangent this morning. So I am going to read a question if there's nobody that's asking a question out here. Alrighty, so let's see. Jason says, if you're a caregiver for your parents, how have you overcome the awkwardness of seeing them naked when you're helping them change into new clothes? So, Jason, I thought that was a great question. And, you know, I totally understand where you're coming from. I am an occupational therapist by background and training, and I have been doing this for almost 30 years. And so I can tell you that when I was a 22-year-old young woman, it was very awkward for me to work with naked people. And you learn over time to just be very aware of it. And usually when I read a question like this, I would be saying that this is more likely a you with your mom as opposed to you with your dad, and that tends to be the problem where people have problems. So the best advice I can give you is a few things, a few practical. Here's a practical strategy, right? If you have to help you're a male child helping a female mom, or a female child helping a dad, there are ways that you can maintain their dignity. Remember, initially, it is if the person is still in the phase where they're aware of it, that's where it's a little more awkward, especially for you. And so what you can do, just a couple of practical strategies. If you're having to help them, you give them as much privacy, but give them indirect supervision. So what I've done with people is take them into the bathroom, sequence them through, if you need to help them with their pants up, pants down, and wiping, you just sequence them as much as you can. You close the door, give them privacy, not all the way close the door. Use mirrors to watch people, so they don't feel like they're, the door's mostly closed, but you can see them in the bathroom, and you can use your mirrors sometimes to make sure that the person's staying safe. You can put a towel over their lap, make sure that you're maintaining their dignity that way. I've used towels or sheets this way. I've used shower curtains to maintain privacy so that I can see what they're doing without actually seeing what they're doing, because you can be in the room and helping the person. The more confident and the less, what's the word I want to use? The less grossed out, or, you know, people with dementia can feel your anxieties. So if you, as a care provider, Jason, in helping a female family member or loved one with private things, if you are like that, they're gonna sense it. So the more calm and confident, and the less big deal you make it, and the more factual, the easier it is for them, and actually the easier it is for you. So you fake it till you make it. So that would be the advice I have for you, Jason. So you can also use, um, you can use strategies of getting them undressed and then just turning your head and giving them their clothes. But like I said, the more factual you are, the easier it is for that person. The more upset you are internally about needing to do this, the harder it is for that person. And remember, at some point or another, they're not going to know, they're not going to care anymore, and then it just becomes, up to you to just, like I said, be factual, get through slowly, not rushed, and just realize that, you know, life came full circle. They did this for you when you were a baby. It's your turn to do this for them. Hey, Moira, good to see you. Happy to have you here. I've missed seeing you out on here. Anybody out there live have any questions for me this morning? We're about halfway through the program. That was Jason's question about how to maintain dignity for your loved one. And I think that was a great question. So Renee said, I plan to provide home care for my mother. Can anyone share recommendations or experiences with adjustable beds? Which brands work well? Sealy, Savata. I do not want a hospital bed. So Renee, I know that there were a lot of people out there who had a lot of different suggestions about beds and and so on. But let's talk about hospital beds for a minute. So when you are adjustable beds are great if the person who has dementia still is pretty mobile. If they can get up by themselves, if they can transfer themselves, having an adjustable bed is very helpful. You can bring the head of the bed up. It helps with so many different things. It can help with acid reflux, right? It can help with positioning legs for edema. It can help with preventing aspiration, etc., etc. But they, in my opinion, are typically more helpful, even though you can put some adjustments on adjustable beds. If they are wide, if they are a double bed or a king size bed, or even if they're one of these split kings where you have people who have, one side can come up and down, all of those are great. But when you get to the point, sorry, my ear's itching. But when you get to the point where a person is needing physical assistance, those beds are not practical. And let me explain why. Why do I say that? Because when you are getting to the point where your loved one, your mom, that you're going to provide home care for, if or when she gets to the point, and I say if because you never know how long a person's going to live, right? We're all going to pass away. Every one of us is going to pass away. And when we have a known diagnosis of some sort of dementia, if that person doesn't pass away from something else, like they have a massive heart attack and die, or if they don't have a massive stroke and pass away, whatever. If a person lives with dementia, lives long enough, then if they are going to continue to progress through this process, they are going to need extensive care, to the point where you will need to feed them, where you will need to change them, etc. A hospital bed, back to Renee's question about providing home care to her mother, about adjustable beds versus hospital beds. Hospital beds are not for the person necessarily with dementia. Hospital beds are for the person who is providing care to that person with dementia. And why do I say that? Because the bed raises up and down. It's a single bed. You have a bed rail. It can prevent the person from rolling off of the bed. A bed rail can be either an enabler, they can help hold and pull themselves, or it can be used to prevent somebody from falling out of the bed. But a hospital bed, Renee, is more for the care provider as opposed to the person with dementia, because when you get to that point where you need that kind of care, you want to be able to raise the bed up and down for you, so that you are protecting your body mechanics, so that you're not, when you're transferring them, bending your back and getting injured yourself. You want to be able to move somebody up and down in the bed. So when you have an adjustable bed that's a double bed or a king size bed or a split king or all of these other different configurations, it can make it very difficult for you as the care provider to actually provide the level of care that they need at home. So having said all of that, Renee, I'm not saying don't necessarily get an adjustable bed, if that's your decision, because it's more comfortable at this point. But what I want you to realize is that the end stages, an adjustable bed may not be enough anymore. It may be something that you actually need to provide your mom with at that time, a hospital bed. But having said that, that also opens the conversation of, at that end stage point, if you wanted to have an adjustable bed for your mom because it's more comfortable than a hospital bed, right, for people. What I would consider is, when you do get to that point, that is when you want to maybe consider hospice, right? We don't get hospice involved soon enough with people with dementia, and hospice has a lot of services that they can provide to help you with your journey. So I hope that was helpful, Renee. I'll tag you in this post. And then I'm going to answer Miss Diane's question. How important is it to get an actual diagnosis? We know she has dementia, but we do not know what kind. That is a great question, Diane, and I hope I do this. I hope I answer this. I hope my answer does this justice. So let's talk about dementia. So what is the term? The term dementia, it's actually a Latin term for dementis, out of one's mind. Okay, so dementia is actually an umbrella term. It's an umbrella term for a lot of different things. And so under the umbrella term dementia, you have little silos of things. One is Alzheimer's. Alzheimer's is a type of dementia. You have Lewy body dementia. You have frontotemporal dementia. You have vascular dementia. You have mixed dementia. All of these are different types of dementia. Is it important to get an actual diagnosis? That is a very yes and no. It depends, I think, on where in your journey you are. There are genetic tests that you can take for finding out if you have a genetic predisposition for Alzheimer's dementia. It's called the apolipoproteins, right? And so when we have certain apolipoproteins configurations, we're more likely to have dementia or not have dementia. As to some of the others, like a Lewy body dementia, they have very certain characteristics, and they, or frontotemporal dementia. And so when we start to get into some of these other dementias, it may be helpful to know whether it's this or this. But it also really doesn't. It can make a difference. It depends on how much hassle factor plays a role. It depends on, like, for example, and I'm going to kind of digress a bit, but like I still work as an occupational therapist, and I have a patient right now who has dementia and has had dementia for a long time. And as I started working with them, Diane, the family wanted to take him to a neurologist because they wanted to kind of know, the one neurologist told them that he has dementia, but they wanted to know, is it Lewy body dementia, etc., etc. And finally, what I told them was, at this point of the game, because he's fairly advanced, I'm like, what difference is it going to make? Because taking him to appointments, so he has hallucinations, he is very difficult to transfer. The more he is stimulated, the more he has challenging behaviors later on in the day. So for them, they had to take him to the doctor this week. They had to get him in and out of wheelchair, out of a hospital bed, in and out of a wheelchair, in and out of the wheelchair van, sitting in a waiting room for 2 hours before they could go in to see the doctor. By the time they got to the doctor, he was so agitated, right? And so my point in using this as an example is that at some point or another, it may or may not be appropriate for us to really know. If you're in the earlier phases and you can take somebody to multiple doctor's appointments, it may make better sense. If you are concerned about a familial dementia, for example, more an Alzheimer's type, or if there's certain characteristics that you're seeing, it may make more sense. But I don't know that it necessarily. A lot of times people follow a very specific pathway, and that's called retrogenesis, which literally means back to the beginning, which is why I like the functional assessment staging tool, is because it uses a developmental milestone, and I talk about this a lot. People develop in the same sequence for the most part, and when people tend to go through phases of dementia, they tend to follow certain fairly consistent phases. If somebody tends to skip something or have a rapid change, it may or may not be Alzheimer's. There may be other ways of looking at it. But I hope that was helpful, Diane. I definitely think that at different stages of dementia, it may make better sense to know exactly. If you just find out somebody has a mild cognitive impairment, it may make more sense to actually try to figure out which type of dementia it is. Medications are more effective at the beginning phases than medication is at the middle to late phases of dementia. So, I'm an expert in my own opinion. I hope that was helpful. Yet again, there are 3 primary ways you can get a hold of me. You can join my Facebook group called Think Different Dementia. You can message me, Lizette Clute at Lizette Clute OT, and then you can subscribe to my YouTube channel called Think Different Dementia. So that gives you a few avenues. Miss Moira, let's see. I just typed the whole question. I've done that before. It's not very difficult. Briefly, if someone has been diagnosed with the specific dementia by expert at a memory clinic, a neuropsychologist, psychiatrist, an psychiatrist, etc., then told if Lewy bodies only, short lifespan, or if vascular dementia 5 years, or Alzheimer's a year, to tell loved ones and or affected people like me. Yes, Moira, you made a very good point. There are certain dementias that are faster than other dementias, and so sometimes in those cases it makes a difference. But I've also had people with Lewy body dementia have it for a very long time. People are different. Vascular dementia, I've had people with vascular dementia rapidly decline. I mean, it's very, a person's dementia journey is complex, progressive, but not it can be very simple, and each person is different. And so we need to remember that people are unique and people are individuals, and each person, because of their uniqueness, because of the way they were created and made, not all of us have the same IQ. Not all of us have been exposed to the same things in our lives, like, right? I grew up in South Africa. My dad was a diplomat. We lived in Sweden, we lived in Brazil, we lived in South Africa, we lived in the United States. I have certain things that I was exposed to that other people weren't exposed to, versus my grandmother who grew up on a farm in South Africa that was exposed to certain other things. Or, for example, my grandfather who grew up in a small town in South Africa called the Odd, which was in the middle of nowhere. He had Parkinson's disease, which they're starting to think Parkinson's disease, which has a strong dementia component. Parkinson's disease may have a lot of environmental factors. So there are all of these different things that make each one of us unique, right? So each one of us, our journey when we develop in our lifespan is different than when we go through dementia. Moira, who grew up in the UK, who I don't remember where in the UK, but say she grew up in London, in a city with certain things in a certain time frame, had certain schooling, had certain experiences, knows certain information, cultural things that play a role. Each of these things make each of our journeys unique and specific. So even though the traits are similar in different dementias, it doesn't mean that each person's journey doesn't look different. I'll go back to my and this was kind of interesting. So I talked about my my patient that I had earlier this week. I've been working with doing my Skills to Care, which is a very specific occupational therapy certification to work with people who have challenging dementia behaviors, and trying to figure out how to modify the task, the environment, the caregiver, as well as the person with dementia, right? So usually there are, when a person is having some sort of a behavior, there's something going on. And it's up to us. A behavior is the person's trying to communicate something to you, and they may not be able to communicate it. So let me use this patient of mine as an example. The very first day I went to go see him, we were talking about what kind of challenges they were having, and one of the big things and why they were kind of leaning towards him having Lewy body dementia is because he has a lot of hallucinations. And so his hallucinations were always kind of at a specific time of day, etc. A lot of sundowning, lots of behaviors going on. But as we're sitting in the house, and the family was absolutely, they're a great family to work with. They want to make changes. They want to help their dad and her husband. They want to do these things. And so they were at the caregiver readiness that I could come in and actually facilitate some changes. So I did my occupational therapy assessment with him, and we're sitting there, and the entire time we're sitting there, he's quiet, nothing's going on, but there's a fan going thwap, 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 thwap in the background, and I'm about losing it, and there's mostly nothing wrong with me. And I'm sitting there, and I said to them, at the end of the session, I said, if you would like to make one change today that I think can make a tremendous difference in your dad's behaviors, I would get rid of that fan. And they all stopped and they looked up and they said, oh. I said, it's making a noise the whole entire time. I said, I can barely concentrate. We're talking, we're dialoguing, and the span's going whack, 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 whack in the background. And I said to them, I'm like, either switch it off or get a new fan or something, because I think that it's overstimulating your dad, because he sleeps in the recliner literally underneath that fan, and our brain right now, like my brain, can tune out a lot of information. I'm sitting here, I have the computer screen, my cat's meowing in the background, I can see there's 7 viewers on here, I'm reading all of this information, I've got a lot of information coming at me, but I can filter that information out, right? Because mostly there's nothing wrong with my brain. But he's not able to filter out that information, the constant verbal or auditory and visual thwack thwack, fan going out. And so I recommended that they do that. And so I've been following up with them now for weeks, and we were sitting there on Thursday. I was at their house, and I asked, this was the day after they had taken him to the doctor and all this stuff going on. And I said to my family member, I said, "How's your dad's hallucinations?" And they're like, "Oh, they're actually much better. He's not hallucinating as much." I said, "Do you think that decreasing that stimulus in the room helped?" They're like, "Yes, almost immediately." So I don't even know why I got down on this tangent. I forgot. But I found, so working with people. I think it had to do with the Lewy body dementia, and so people's progression. But every person is an individual and unique individual, and we have to look at their specific environment, their specific stuff going on in their lives. We got to know what they did it for a living. That can help us. If somebody's being, I call it a jack in the box, right? They up and down, up and down, up and down. What's causing it? What kind of job did they have? We don't know, and so that's how we become the dementia detective, to try and help our loved ones through these different challenges. So if you are having challenges with your people with dementia, or loved ones with dementia, I can give what I call general specific information, but I will tell you, Skills to Care, and I don't know Melissa's out here. Melissa, I think, is also doing Skills to Care. Skills to Care is like phenomenal, because I've been doing this for 30 years. It has made such a difference in my practice, because I now can find and identify the triggers that people are having. And so I can give you guys ideas or things going on, but if there's truly something going on, it's literally specific to that person. And it may be so specific to that person and that environment and that particular caregiver, that giving general strategies out here, in the group, can be a little bit helpful, but it may not solve the whole problem. So if you're actually challenged that way, please reach out to me. We do I do consulting too. So just let me know if there's anything I can do to help. Hey Eunice, how's South Africa? Are you cold? Is it winter yet? Is it getting there? It's good to see you out there. All right, so Tracy had another question, since I don't have a question out there yet, unless somebody out there has a question for me. Tracy said, "At what point did everybody or everyone decide to put their loved one in a facility? My dad is not really combative yet, but challenges my mom a lot. My mom is struggling, but I know she'll feel guilty for putting him somewhere." So Tracy, that was Tracy's question. So at what point did everybody or anyone decide to put their loved one in a facility? My dad is not combative yet, but challenges her a lot. My mom is struggling, but I know she'll feel guilty for putting him somewhere. Hey, Kennelly, good to see you too. So Tracy, that is a good question, and I'm going to answer that question in this way. Nobody can answer that question excepting you. Right? I do not believe that it is evil or sinful or wrong to put somebody in a facility. I am not one of these therapists that say people need to be at home. No if and or buts. And Canelli, I'll answer that in a second here. No if and or buts, right? I do not believe that you have to keep someone at home. Having said that, I also don't believe anybody else can tell you somebody needs to be in a facility. It depends. It depends on so many different factors. It depends on the size of the care providers. Like, for example, back to my patient that I have right now. He is 6 foot tall, big guy, always had been a big guy. Wife is 5'1", not a big person. She described it as he's resistant to her care. I go in, he does fine with me, he does fine with other people, but when she tries to help him, he's resistant to her care. We finally figured out he's afraid because he knows he's so much bigger than her. He's always been so much bigger than her. She's the one doing the lifting and he doesn't want to hurt her. So it depends, right? The size of the care provider, the size of the patient. If your loved one is 400 pounds and you weigh 100 pounds, it may not be safe for you to be providing that level of assistance at home. If somebody is combative, and it's hard for two people, if it takes two people to manage them, if there are other safety concerns, if the person who is providing the care of the person that they love with dementia, if they are providing the care, and it's physically affecting them so much that now we have two patients, there's so many factors. Nobody can decide for you who is when is the right time to have somebody placed in a facility. That is up to you. Having said that, I will tell you for the past year, it has been very different in a facility. You know, in the normal run of things, it was different where family members could go in and see their loved ones and so on. So I think there's so much going into this question, Miss Tracy. Nobody can answer that for you but you. Everybody's natural support systems are different. If you're in a church and you have access to people who can come sit with someone, so nobody can answer that question for you but you. If people have enough financial resources to be able to provide their loved one with some additional physical assistance in the house to give the person with who is the care provider rest, like the family that I'm working with right now. One of the very first things we did is we got a book. We got a calendar, and they started to fill in. This is when somebody's coming in for 4-hour blocks so mom can get out of the house because she was not having any rest. So to answer your question, Tracy, everybody has to decide for themselves when is the right time. If it's the right time, are they going to do this? And if they're going to do this, when, what's the line in the sand? I think it's better if you are a family that know for a fact that it doesn't matter what happens, you're going to keep someone at home. Start to plan for it. If you're the family that knows for a fact that you are not going to be able to keep somebody at home, start to plan for it. And if that is the case, sometimes having them move to a facility earlier on is a better option, in my opinion, so that they can transition to a facility easier, using their retained abilities at the beginning to be able to learn a new routine, to be able to find their room, to be able to do all of these additional things. So lots of considerations that go into how to make the decision whether or not to have somebody in a facility or not. So Kennelly, that is a great question. Is hoarding and Alzheimer's connected? Yes and no. So I actually answered that question for you, and I tagged you in the post in Think Different Dementia. So if you want to go look at that video, but I will quickly, briefly answer that here again because I'm sure other people may have the same question. So hoarding can come in a lot of different ways, and I think people hoard for a lot of different reasons. Back to the beginning of the conversation, people with dementia have, as they start to lose their executive functioning skills, they start to lose the ability to scan their environment and sort out information. So sometimes I think people who are, quote, hoarding literally aren't necessarily hoarding. It's just that they keep everything out because otherwise they can't find it. So when I go to patients' houses and there's a lot of clutter, I start to wonder, are we having trouble thinking? You start to dig a little bit more. My house has a fair amount of clutter right now because I'm trying to start a business and we've got all this stuff going on in our lives, right? So hoarding can be a sign of Alzheimer's, but it's also, probably a sign of their cognitive abilities changing. We have to be, some people were collectors their whole life. They collected things. Like my parents, I wouldn't say that they're hoarders, but they, for a long time, they collected little knickknacks, right, from all over the world. So hoarding and Alzheimer's can be connected. I answered the question in Think Different Dementia. So if you are interested in more information about hoarding and Alzheimer's, join my group Think Different Dementia, and then look for the videos that I do there on a Tuesday night called Dementia Made Simple. There's one that says Hoarding and Kennelly. I tagged you in that one, so I'd love you to go watch that one because I actually answered that a little bit more in depth. So I hope that was helpful. If you cannot find it, Kennelly, email me and I'll try to post it. I can try to send you the link if you'd like. So yet again, this is Saturday, May the 8th, the day before Mother's Day. Thank you for joining me here today. This was the Baffled Brain Demystifying Dementia, where I'm trying to provide you with reliable information and actionable strategies to help your loved ones who may or may not have dementia negotiate or go through this journey. I want you to know you're not alone. There are three primary ways for you to contact me. You can message me, Lizette Kluta OT, at Lizette Kluta OT. You can email me, thinkdifferentdementia@gmail.com. You can join my Facebook group called Think Different Dementia. And then thank you so much for coming on this beautiful Saturday morning in South Carolina. And as I always end these programs, the Lord bless you and keep you. I will be back again next week. If you like what you're seeing, please invite friends to watch, invite family members to watch, and I will be back again next Saturday. Bye.